essentially, when people lose their nephrons, we've got chronic kidney disease. And chronic kidney disease begets chronic renal failure, that's CRF. For those who have chronic renal failure, they develop end-stage renal disease, ESRD, okay? So, know those acronyms, and it's an easy way to study. It's literally a linear progress. CKD to CRF to ESRD, right? So what is, oh, you guys all got my emails, right? Or my email with the links. Alcohol and cancer. Some people think I make this shit up, or it's like I'm a teetotaler, or I just want to make people's Thursday evenings miserable. I don't. The stuff that came out about alcohol being related to alcohol and cancer, yes. Okay? Obesity is its own risk factor. Yeah, guys, for real. Okay? So if you haven't read them, read them. And let me just say this to you. I swear. So this is America, right? So Journal of Oncology is an extraordinarily well-respected medical journal. All right? The New York Times carried an article in the morning summarizing what that journal article had to say. By 4:30 New Mexico time in the afternoon, their editors blitzkrieged their readers with 3 other articles that said, come on, you know, there's always like something that kills people, whatever, get over it. You know, we've known about some risk, it's not a big deal, you have to drink a lot. Yeah, okay. Remember, science, empirically verified, the only thing that matters, okay? So, why is chronic kidney disease a worldwide problem? Because people have hypertension and diabetes mellitus. Type 2 diabetes, the kind we'll talk about that you earn your gold medal for not taking care of your body. Okay? Oh, and the other one was about high blood pressure. Okay. So I've whined, you guys heard me whine and we had bullshit categories, right? I whined before the article came out. The article comes out, and guess what? And I'm telling you, there's a really cool little cardiac risk calculator that's embedded in the article. You guys have lab results from, you know, recent lab, lipid panel, and you can get all that as part of your maybe soon to be extinguished affordable health insurance, whatever the hell that means in this country. But the cardiac risk calculator that's embedded in the article is actually legit. It's exactly what MDs use, okay? So if you have a lipid panel, you can get a free, you should be able to get, as part of your annual, some free or really inexpensive lab work done. You know, get your pressure and put it in. And you notice, when you take a look at the stuff that they looked at for risk factors, they didn't ask, what's your weight? Okay, they didn't ask that. And, I mean, gender is important, age is important, but they didn't ask what's your weight, they didn't ask what's your BMI. Okay? Why? Because slightly elevated blood pressure all by itself is its own really serious risk factor. So what are the new findings? Not new findings. I mean, they are new findings, but everybody knew about it for a long time. It's just, you know, we're Americans, so we take pills and we define categories and pretend we're healthy. Right? That's who we are. And, you know, if you have 132, 135 over 86, guess what? Now we actually get to look at you and not feel bad. You have high blood pressure and you need to do something about it. Okay? So what do you do when you have slightly elevated blood pressure or really elevated blood pressure? You screw your kidneys. What happens when you have diabetes? Well, everything goes to hell, so do your kidneys. Okay? So what's chronic kidney disease defined as? So remember the respiratory unit, chronic bronchitis, that was important. How many months? This is important. okay, for test purposes. It's decreased kidney function or kidney damage that's been measured for at least 3 months, okay? Or you get lab work done that consistently says that your GFR is under 60. Does that make sense, everybody? Okay. So, who's at risk most for chronic kidney disease? Remember, chronic kidney disease begets chronic renal failure, begets end-stage renal disease. I have a student in another class who I consider to be a friend now, also, and this particular person has a significant other in his or her life who has at most 15% renal function. And so this particular person is going to go in for the sit down on Monday or Tuesday next week and talk about whether or not to do dialysis. Now listen, you understand, right, what that means, whether or not to do dialysis? Want to die quicker or a little bit slower? You hear me? How did this person get to where they're at? Diabetes and obesity. That's it. How old is this person? 49. That's 7 years younger than me. Scary stuff, guys. Okay? Really scary stuff. So, what other things can get you into chronic kidney disease? Hypertension, we just talked about that. Pyelonephritis, recurrent kidney infections. Listen, when somebody has recurrent kidney infections, you have to figure out what the hell is going on. Okay? It's not just enough, oh yeah, we'll put you on a bunch of antibiotics. That's insufficient. It's not sufficient and appropriate medical care. You have to actually get to the bottom of why the patient's getting it. Because, listen, what is pyelonephritis? Itis, inflammation. Every time there's flipping inflammation, and then when there's recurrent inflammation, when there's recurrent inflammation, what is there? The building up of scar tissue. The destruction of nephrons, and that means the reduction in kidney function. Does that make sense to you guys? Okay. Polycystic kidney disease, we talked about that last week. Bottom line is, what happens with all of these things? You change the GFR. Why? Because you're harming the nephron, okay? So listen to me. If you're changing the GFR and you're harming the nephron, what does the kidney do and what does the body do? It responds in kind, and it does all of its compensatory factors, right? So you get sympathetic nervous system activity, Bartrea, from good questions before class began. So you get sympathetic nervous system activity. Why? Because the body says, hey man, the long-term regulator for the blood pressure isn't doing its job, and there's insufficient filtration going on, so hey, let's just jack the pressure up. But it's a never-ending feedback loop because you lost nephrons, so the sympathetic nervous system keeps on maintaining the slightly elevated or maybe not so slightly elevated blood pressure. Does that make sense to you guys? And that causes cardiovascular issues, right?
Does it reset the...
It doesn't do reset. It's just its own separate compensatory mechanism. And as long as the pressure stays low in the nephron, the response is going to be, hey, we can't deal with this. We're going to keep on triggering the sympathetic nervous system. Okay? It's not a reset. It's just a constant trigger. And that's bad. Okay? Then what else happens? Well, the renin-angiotensin-aldosterone cascade keeps getting triggered. So that means we're constantly retaining sodium so we could retain water to do what? Build up the vascular compartment. To do what? Have sufficiently high blood pressure. To do what? Adequate GFR. But we're never going to get it, you say. Right. All the compensatory mechanisms that work in you and I actually start harming the patient that's got kidney disease. Does that make sense to you guys? Okay. So there's two ways we monitor this. One is either reduction in GFR, we're going to look at that, or percentage of nephron loss. In principle, the two are correlated to each other, right? The fewer nephrons you have, the lower the GFR. Does that make sense? Okay. So I want you guys, here's what I want you to know from this slide. Now listen, it's so insane what's up on the first point. I don't want you guys to miss it, okay? So I'm not being intentionally dramatic. It's extremely important. You could literally lose almost up to 3/4 of your flipping kidney use before there's any change in your BUN or creatinine. You guys got that? So listen, what the hell does that mean? Here's what it means. It means that when you get a lab result back and the BUN and or the creatinine have changed and they're in the wrong territory, that means some serious crap is going on in the kidneys. The good news is maybe it's just acute tubular necrosis, which can be turned around. We talked about that last week, okay? So we define no signs or symptoms. You might not even be diagnosed, up to 3/4 lost. Listen, that doesn't mean that the person can live another 40 years with 3/4 loss. Hell no. What happens with 75% loss, eventually you are going to get symptoms. You're going to have persistent azotemia, so you got the nitrogenous wastes floating around the body, not being cleared out, and you develop some horrific systemic conditions. Okay. When you have between 75 and 90% of your nephrons that are lost, you're starting to pee a lot, and you're getting up at night. But I always get up at night. Well, then it's not a big deal. If you've never gotten up at night and you're not taking any sympathomimetic drugs before you go to bed, and you're not drinking alcohol right before you go to bed, and you're not drinking, oh shit, I didn't drink water all day today, I think I'll drink 36 ounces 30 minutes before I go to bed, well, you're going to get up at 8, okay? Because if you don't, there's going to be a problem. So that starts to develop. That starts to develop when you're almost down to 10% usage on the day, okay? And look, slight elevation in BUN and creatinine. Just slight, okay? It might be controlled by diet and medication. Now that's interesting. What does that really mean? You don't qualify for dialysis or for renal transplant. But Jim, at 90, whatever, at almost 90, at 85% renal loss, so how come this person that you talked about earlier, they're going to sit down and talk about dialysis? She has a very aggressive healthcare team that know how to dance around the regulations. So if the patient says, yes, I'm up for dialysis, what they'll do is they'll put it in as an emergency, temporary dialysis, and then they'll run some studies in a month and say, you know what, we can't pull her off, and that way then insurance will pay. Does that make sense to you guys? I hate to say it, but that's the way the game has to be played, okay? The other thing is I want you to know ESRD. ESRD, by definition, is you've lost 90% of your nephrons, or the use of them, okay? That's when you qualify for dialysis and or renal transplant, but it depends what caused the renal problems if you get the transplant, right, Sapna? Yeah, there's a lot of, it's not straightforward. Hey, the patient needs a kidney. That doesn't mean anything necessarily, okay? So, you get azotemia and uremia. Bottom line is, everything the kidneys did goes to hell. So nitrogenous wastes are still floating around. The kidney's not able to respond to PTH to retain calcium, so the bones get weak. The kidney's not able to do the hydroxylation of vitamin D, so the calcium that's in the small intestine lumen can't get absorbed adequately. You get bone deficiencies, okay? Erythropoietin goes to hell. You have to have synthetic erythropoietin injected because otherwise you develop anemia. Because remember, it's the kidneys that send the signal to the bone marrow, make more red blood cells. Does that make sense to you guys? Okay. So talk about that. The other way is to measure GFR. So I'm going to give you a word. The only true way to measure, actually measure, directly measure GFR is to put in inulin. It's the only thing that we know that's completely benign to the human body. It is not remotely metabolized by any part of the body. It doesn't stay in the body, and it gives you, so you've got somebody at a certain drip rate in an IV. With an IV, you put, or not an IV, you can put it in other ways. You can measure very specifically how much inulin you put in. Did they use that for you? Okay, so you put the inulin in and you can measure the inulin output very specifically. And so when I say, when we're looking at stages 1 through 5, we're talking about using inulin or something like inulin to measure. But Jim, on a typical CBC and metabolic panel, they always say what my GFR is. It's calculated indirectly, guys. You can actually look the equation up on the web. No one's actually measuring at all. It's a very rough estimate, okay? So, stage 1, listen, that's boring. Let's get down to stage 3. So stage 3, what's the normal GFR? 125, right? And I want you guys to know that it's supposed to be 125. But as I stand here, I know mine isn't. Why? Because I'm old. I'm in my 6th decade. Okay? You mean 60s? No, guys. 50s. Jerks. Yeah, you guys are so going to hit 60s also someday. So the bottom line is it's considered moderately decreased if it's between 30 and 60. I'm not saying that healthcare providers happy when you're at 40, but real honestly, listen, real honestly, what do you do? Dietary restrictions. Dietary restrictions, like what? Significantly reduce protein. Why? Because they're made out of amino acids, lots of nitrogen, and also potentially reduction of nucleotides because they have what? Lots of nitrogen in them as well. Right? Does that make sense to you guys? So what does that mean? So that means you got to load up on carbs and or fats? Yeah. But that's harmful. Yeah, but nobody asked you to become a diabetic, right? And then you trashed your kidney. You don't actually have this conversation with the patient unless you're at the preemptive stage, right? Hey man, your hemoglobin A1C came in at 6.2. Yahoo! No, boo! Okay? You hear what I'm saying, guys? I'd love to see we're Americans, so whatever. It's somebody else's fault if I failed an exam. It's somebody else's fault if I had a heart attack. It's somebody else's fault if my kidneys aren't working. That's what it means to be American. I mean, I hate to say it, but it does. And we can't say anything that messes with people's, personal dignity. But damn it, higher than 130 was high blood pressure, for crying out loud. Thank God we can say that now, all right? And we say it because we care. Of course it's because we care. So, diabetes and or obesity. Guys, many of you, the only thing that's wrong with the patient is that they haven't eaten right for a long time, they haven't exercised. Everything else is okay. They're just starting to walk down that precarious path that doesn't lead to roses, okay? End-stage kidney disease, look at that. It's a GFR of less than 15. What? Right, supposed to be 125. In your 6th decade, it's like, whatever, it's in the 60s. God bless, it's okay. All right? But less than 15, what does that mean? That means that stuff is floating around in your body all of the non-dialysis hours. So let's dispel another myth. So sweet, I got the little portable unit. That means they think that I'm okay. What? No, they don't. The portable thing was invented and peritoneal dialysis was invented to try and keep people able to be as functional as long as possible. Because everybody that's on the portable unit, if they make it, they're going on the regular, sit down in the clinic, doing it 3, 4, 5 hours. Okay? Does that make sense to you guys? If you hear somebody say, sweet, they're putting me on the portable one, oh, thank God, I thought it was serious. Oh, it's serious. Okay? You're never regaining kidney function again. And that's a bad thing. Alright? Complications, obviously you guys know, right? If the kidneys are the long-term blood pressure regulator and they go to hell, you got all kinds of cardiovascular problems. And why does hypertension come about? Because what are we doing? Triggering the sympathetic nervous system and triggering the renin-angiotensin-aldosterone cascade, so we're retaining salt so we can build up the volume. Does that make sense to you guys? Well, what do? We become hypervolemic, blood pressure goes up, and then we develop cardiac issues, okay? And then respiratory issues, and there's no turning back. Obviously electrolyte imbalances, I don't care about that, we talked about that. So, prevention. Well, how do you prevent degenerating into chronic kidney disease and ultimately ESRD? You obviously have to identify risk factors early. Are you drinking alcohol? Yeah, it's a problem. How much caffeine are you having? Well, pause, let me fill in. Any is too much. So, finish your sentence. I'm old. I accept my risk. I'm 56. Okay? I'm not being a hypocrite. Jim, how much other caffeine have you had today? Shamefully, only a half a cup. I left early from the house today. As I'm driving away, late for a meeting, I was like, oh, damn it, I didn't finish my coffee. So this is my attempt to restock. Okay? Early identification. Are you obese? Are you at risk for diabetes? Do you have high blood pressure? Okay? Are you on long-term meds for some other underlying disease process? Are they renally cleared or hepatically cleared? Are they renally toxic? Okay? Does that make sense to you guys? What kind of salt do you have in your diet? Ouch! How much salt do we need to add into our diets?
No.
0. But food tastes so bland. Wait, really? Use real spices. India's got a ton that are really amazing. Okay? The Far East does. The Middle East does. Southern Mediterranean does. And none of those spices cause problems. Okay? So, the other thing is, if you have a patient who's got a renal issue, the minute they get an infection, you have to eradicate the infection. It doesn't matter where the hell it's in the body, you have to eradicate the infection quickly. Why? Because what do we do when we have an infection? We generate an inflammatory response. If we have deteriorating renal function and a heightened immune system response, the inflammatory response is going to potentially harm the kidneys. So you have to do aggressive treatment of infections. About this.